Welcome back to Oral Medicine Simplified. In this lecture, we begin a focused three-part series on oral erythroplakia, one of the most clinically significant oral potentially malignant disorders. This series has been intentionally divided into three parts because erythroplakia should not be approached as a simple definition-based topic. It requires clinical recognition, diagnostic judgment, biopsy planning, histopathological understanding, and careful patient management. In part 1, we'll focus on clinical recognition, risk factors, common sites, symptoms, red flags, and differential diagnosis. The purpose of this lecture is to train your clinical eye so that when you see a persistent red patch in the oral cavity, you know how to think, how to examine, and when to refer. The central message of this lecture is simple: a persistent, unexplained red oral lesion should never be ignored. This roadmap shows how the erythroplakia series is structured. In part 1, we recognize the lesion. We will discuss what erythroplakia is, how it presents clinically, what risk factors are important, and how it differs from other oral lesions. In part 2, we confirm the diagnosis. That lecture will focus on history taking, clinical documentation, biopsy planning, and histopathology. In part 3, we manage safely. That part will cover management according to histology, patient counseling, habit cessation, recurrence risk, and long-term follow-up. So, this series follows a clinical pathway: recognize the lesion, confirm the diagnosis, and manage the patient safely. By the end of this first part, you should be able to recognize erythroplakia clinically, differentiate it from common red lesion mimics, understand why dysplasia risk is important, identify the clinical features that should raise suspicion, and understand why proper diagnosis is necessary. This lecture is designed for BDS students and postgraduate students, but the clinical message is very practical. Whenever you see a persistent red patch in the mouth, you should not simply describe its color. You should ask, what is the duration? What is the site? Is it symptomatic? Is there induration? Are there risk habits? Could this be a mimic? And does this lesion need biopsy or referral? That is the level of clinical thinking we want to develop. Erythroplakia is clinically important because it may appear deceptively simple. It may look like a red patch, it may be painless, and it may not appear dramatic at first glance. However, histologically, a true persistent erythroplakic lesion may already show severe epithelial dysplasia, carcinoma in situ, or invasive squamous cell carcinoma. Since we have already covered leukoplakia in a separate detailed series, we will not spend time revising leukoplakia here. I'll only mention one short clinical contrast. Leukoplakia is more commonly encountered, whereas erythroplakia is less common, but often more alarming because of its higher association with serious histopathology. From this point onward, our focus remains completely on erythroplakia as a red, high-risk clinical warning sign. Oral erythroplakia is defined as a red patch or plaque of the oral mucosa that cannot be clinically or pathologically diagnosed as any other disease. The most important phrase here is diagnosis of exclusion. This means that erythroplakia is not a label we apply to every red area in the mouth. Many oral conditions can appear red, including trauma, candidiasis, denture stomatitis, erosive lichen planus, lupus erythematosus, pemphigus, vascular lesions, and squamous cell carcinoma. So, erythroplakia is suspected when a red lesion is persistent, unexplained, non-scrapable, well demarcated, and not fitting another recognizable diagnosis. A good clinical way to remember this is erythroplakia is not suspected simply because a lesion is red. It is suspected because a lesion is persistently red without a better explanation. Here we emphasize on a very essential clinical point that Not every red lesion is erythroplakia. A red lesion may be inflammatory, traumatic, infective, immune-mediated, vascular, or malignant. Therefore, the clinician must think broadly before assigning a diagnosis. However, thinking broadly should not become a reason for delay. If a red lesion has no obvious explanation, persists after removal of possible causes, occurs at a high-risk site, or shows suspicious clinical features, the correct pathway is biopsy or referral. This is why the repeated rule throughout this series will be persistent, unexplained red patch equals biopsy or referral. Clinically, oral erythroplakia typically appears as fiery red, velvety, well-demarcated patch or plaque. It may be flat or slightly depressed. It may be smooth or granular. It is usually non-scrapable. The margins may be clearly visible against the surrounding mucosa, and the surface may appear delicate or velvety, but the lesion does not have to look dramatic to be dangerous. Some erythroplakic lesions may look subtle, especially in the early stages. This is why clinical judgment is essential. A small, persistent red patch on a high-risk site may be far more significant than it appears. The red appearance of erythroplakia can be understood by looking at the underlying tissue changes. In many cases, the epithelium is thin or atrophic. Keratinization is reduced, and the vascular connective tissue underneath becomes more visible. So, the red color is not merely a surface feature, it reflects the altered epithelial thickness, reduced keratin protection, and increased visibility of the underlying vascular tissue. This is clinically important because a thin, abnormal epithelial surface may already show dysplastic change. So, when we describe a lesion as red and velvety, we should remember that the color may represent deeper biological significance. Erythroplakia belongs to the group of oral potentially malignant disorders, commonly called OPMDs. These are the lesions or conditions that carry an increased risk of cancer development. In oral medicine, oral potentially malignant disorders are important because early recognition and timely diagnosis can significantly influence patient outcomes. Erythroplakia is one of the most important oral potentially malignant disorders because although it is less common, it has a strong association with severe epithelial dysplasia, carcinoma in situ, and invasive squamous cell carcinoma at diagnosis. So, we should not teach erythroplakia as just a red lesion. We should teach it as a clinical warning sign that requires structured assessment. This comparison is included only briefly because leukoplakia has already been discussed in detail in a separate series. Leukoplakia is a white lesion and is more commonly encountered, while erythroplakia is a red lesion and is less common. However, erythroplakia is often more concerning because a true persistent red lesion is more likely to show severe dysplasia or carcinoma at diagnosis. So, the purpose of this comparison is not to revise leukoplakia. The purpose is to highlight why erythroplakia deserves urgent clinical attention. The key message is that when the lesion is persistently red, unexplained, and suspicious, the threshold for biopsy or referral should be low. The clinical pearl for this lecture is a persistent, unexplained red patch should never be ignored. It may be painless, it may not bleed, it may not look ulcerated, but if it persists, especially in a high-risk site or in a patient with risk habits, it must be investigated. This is one of the most important habits to develop as a clinician. Do not wait for cancer to look obvious before taking action. Early lesions may be subtle. Safe clinicians recognize risk before the disease becomes advanced. Erythroplakia is relatively rare compared with many other oral mucosal lesions. However, rarity does not mean low importance. In fact, because it is uncommon and high risk, it should be treated with serious clinical attention whenever encountered. It is more commonly reported in middle-aged and older adults and is often associated with oral cancer risk factors such as tobacco, alcohol, and areca nut exposure. However, age alone should never be used to dismiss a suspicious lesion. If a red patch is persistent and unexplained, it requires appropriate evaluation regardless of the patient's age. The risk factors for erythroplakia overlap with the risk factors for oral squamous cell carcinoma. These include cigarette smoking, smokeless tobacco, alcohol use, areca nut, pan, gutka, naswar, and chronic mucosal irritation. However, one point needs emphasis. Chronic irritation may produce red mucosal changes, but it should not be used as a convenient explanation for every persistent suspicious lesion. If a sharp tooth, restoration, or denture is suspected, the irritant should be removed and the lesion should be reassessed within a short interval. If the lesion persists, biopsy or referral is required. In Pakistani and South Asian clinical practice, risk habit history must be very specific. Many patients may say they do not smoke, but they may regularly use pan, chalia, gutka, naswar, supari, mainpuri, or other chewing products. If we ask only, do you smoke? We may miss the most relevant risk factor. A better question is, do you use tobacco or areca nut in any form? Then give examples like pan, chalia, gutka, naswar, supari, mainpuri, or any chewing products. This is not just routine history taking. This is oral cancer risk assessment. Erythroplakia can occur at several oral sites, including the floor of the mouth, ventrolateral tongue, soft palate complex, buccal mucosa, gingiva, and the alveolar mucosa. Site matters because certain areas of the oral cavity are considered higher risk for dysplasia and carcinoma. Therefore, a complete oral mucosal examination is essential. Do not restrict the examination to teeth and gingiva. Examine the buccal mucosa, tongue, floor of the mouth, palate, alveolar mucosa, gingiva, and oropharyngeal region systematically. A suspicious lesion can be missed if the examination is rushed. The ventrolateral tongue and the floor of the mouth are especially important high-risk sites. A persistent red patch in these areas should never be dismissed casually. These sites are commonly emphasized in oral medicine and oral pathology because they are frequently associated with oral epithelial dysplasia and oral squamous cell carcinoma. For students, this is a high yield point. Lateral tongue and floor of the mouth are danger zones. Clinically, if a red lesion is present in one of these sites, especially with tobacco or areca nut history, the threshold for biopsy or referral should be low. One of the most dangerous features of erythroplakia is that it may be asymptomatic. The patient may not complain of pain, burning, bleeding, or swelling. Sometimes the lesion is discovered incidentally during a routine oral examination. Some patients, however, may report burning, pain, bleeding, irritation, but symptoms are not reliable indicators of dysplasia. A painless lesion can still show severe dysplasia. A painful lesion may be inflammatory. So, the clinical message is absence of symptoms do not mean absence of risk. Clinical examination must include both inspection and palpation. Inspection helps us evaluate the color, size, site, surface texture, borders, and whether the lesion is red, white, mixed, ulcerated, granular, or smooth. Palpation helps us assess consistency. Is the lesion soft, firm, fixed, tender, or indurated? Induration is particularly important because it may suggest invasive disease. Also, examine the cervical lymph nodes because oral lesions should not be assessed in isolation. So, the correct examination approach is inspect, palpate, document, and check the neck notes. The red flags that should immediately raise suspicion include induration, ulceration, nodularity, friability, spontaneous bleeding, mass effect, persistence, and location at a high-risk site. If any of these features are present, repeated empirical treatment without diagnosis is unsafe. A suspicious lesion should not be treated with multiple rounds of mouthwash, antifungal therapy, or topical medication without reassessment. The safer clinical approach is timely biopsy or referral. The important principle is do not delay diagnosis when the lesion is behaving suspiciously. A red oral patch has a broad differential diagnosis. It may represent candidiasis, it may represent denture stomatitis, trauma, erosive lichen planus, lupus erythematosus, pemphigus, vascular lesions, or early squamous cell carcinoma. This is why erythroplakia is a diagnosis of exclusion. We must consider all of these other possibilities before labeling the lesion. But we must also remember that differential diagnosis is not meant to delay action. If the lesion is persistent, unexplained, or suspicious, biopsy or referral is required. The safe clinical mindset is think broadly but act promptly when the risk is present. Erythematous candidiasis may present as red, burning oral mucosa. It is more likely in patients with diabetes, xerostomia, antibiotic use, steroid inhaler use, immunosuppression, or denture-related problems. If the clinical picture supports candidiasis, antifungal treatment may be appropriate. However, reassessment is essential. If the lesion resolves, that supports the diagnosis, but if it persists or if it looked suspicious from the beginning, biopsy or referral should not be delayed. A persistent red patch should not be repeatedly treated as candidiasis without confirmation. Erosive oral lichen planus may produce red erosive areas, often with pain or burning. Usually there are additional clues such as bilateral involvement and white lace-like Wickham's stria. Erythroplakia is usually more localized, well-demarcated, red, velvety, and unexplained. However, clinical distinction is not always easy. Atypical, unilateral, persistent, changing, indurated, or non-healing lesions should be biopsied. So, even when lichen planus is considered, atypical features must not be ignored. Vascular lesions may appear red, blue, or purple. One useful clinical test is blanching. When gentle pressure is applied, a vascular lesion may become pale because blood is displaced from the area. Erythroplakia usually does not blanch because it is not simply a blood-filled vascular lesion. It is primarily an epithelial mucosal lesion. Blanching can help with clinical reasoning, but it does not replace diagnosis. If uncertainty remains or if the lesion is persistent and suspicious, referral is still a safer option. So let us summarize part 1. Erythroplakia is suspected when a red lesion is persistent, unexplained, well demarcated, non-scrapable, located at a high-risk site, or associated with risk habits. Not every red lesion is erythroplakia, but every persistent, unexplained red lesion deserves careful examination and proper diagnosis. This is the clinical discipline we want students and clinicians to develop. Do not ignore subtle red lesions simply because they are painless or small. This brings us to the end of part 1 of the Erythroplakia series. In this lecture, we learned how to recognize erythroplakia clinically, why persistent red lesions matter, which risk factors are important, where high-risk sites are located, why symptoms may be absent, how to examine the lesion, and how to differentiate it from common mimics. In part 2, we'll move from clinical recognition to diagnostic confirmation. We'll discuss history taking in more detail, documentation, biopsy planning, incisional and excisional biopsy, adjunctive tools, and histopathology. And remember, if there is persistent, unexplained red patch, you do not ignore it. This is Dr. Suman signing off, and you're watching Oral Medicine Simplified. I'll see you in the next part of Oral Erythroplakia series.